Yeah, and for most things in life, like gradual exposure or graduated exposure is a powerful tool. It sounds very simple because it is very simple, but done over time, it's like it's magical what people can do if you just start doing a little bit and keep doing it. So, you people always overestimate what they can do in a month, but they always underestimate what they can do in a year. Like if you just stick with it for a year, you will do more than you thought you would do, and it's just hard to get people to stick for it that with it that long without getting discouraged sometimes. But if you just think of what three things can I do this today to get a little bit stronger, to challenge myself, it will just keep going forward most of the time.
I'm Jessica Valant. I'm a physical therapist, women's health expert, and Pilates teacher, and my goal is to help all women feel strong, safe, and secure in their bodies. In this podcast, I'll share expert advice, facts, amazing guests, stories, compassion, and hope to help you meet your body in all seasons of life. One of the best parts about my job is getting to talk to really cool, really smart people who are out there using their platforms and just using the tools that they've been given to help empower and support others. And that is what today is about for me. So we are talking to Dr. Nidhi Sharma. And let me tell you a little bit about Nidhi. So I found her online, actually on Instagram. One of the good things about Instagram is delivering the feeds of really great people right to me. So she is a pelvic floor physical therapist, and I noticed that her words, her message, they all are about empowering women to still move their bodies, exercise, lift weights, all the things, even with pelvic floor dysfunction, even with prolapse. And I just knew that I needed more of that in my life. And today's conversation is so amazing for so many of you out there who have been through any kind of injury, issue, pain with your pelvic floor, and are looking for that message to tell you that not only is it okay to move, but it's actually beneficial. You will improve and help your healing by moving your body. So let me tell you a little bit about Nidhi. So Dr. Nidhi Sharma is a pelvic health physical therapist with over 15 years of experience in helping people recover from injuries and regain function. She is double board certified in orthopedics and pelvic health through the American Physical Therapy Association. Her passion is to help women overcome pelvic health challenges in pregnancy, postpartum, and beyond. Her goal for her patients is for them to understand their body and take ownership of their health. When not treating patients, she'll often be found speaking at local support groups and community events or teaching in childbirth education classes to raise awareness about pelvic health. She is also involved in teaching physical therapists and fitness professionals in the specialty of pelvic health. This is one of those conversations that just left me pumping my fist in the air, celebrating people out there doing really great things to help others and to talk about the benefits of movement and living a positive outcome filled life with your body. So I'm so excited to bring to you today my conversation with Dr. Nidhi Sharma. Hi, everybody. Thanks again for being here for Meet Your Body. I am so excited for today's conversation. If you followed me for a while, you know I talk about pelvic floor health a lot. We talk about prolapse a lot here. And when I found our guest online, and I can't even tell, that's one of the beauties of Instagram. Like Instagram just fed me your feed. And like, yes, this is someone I'm going to follow. This is someone I'm going to talk about. Whenever someone is talking about pelvic floor health from a place of both science and anatomy and empowerment, I want to talk to that person. So that is what we're talking about today. And Nidhi, thank you so much for being here.
Thank you for having me, Jessica. I'm really excited.
So tell us just everything you want us to know about you, like introductions, your story, whatever you want us to know. I would love to hear.
Okay, so I am a physical therapist. I have been a physical therapist since 2008. And my introduction to pelvic health happened sort of accidentally because I had a coccyx fracture, a tailbone fracture,
Okay.
when I was in PT school many years ago. I was in PT school, had coccyx fracture, was in pain for 3.5, maybe 4 years, treating
Wow.
patients with back pain, but I
Wow.
had pain. And, I had a shot, other things, nothing really helped. And there's like, well, we could do surgery, take your tailbone out. I was
Yeah.
like, well, that's intense.
Yeah.
So, I ran into a pelvic floor therapist on one of my orthopedic courses, and she's like, I can help you. I think I can help you. And it's insane. Like, we hear this from patients all the time, but she fixed my 4 5 year long pain in
Wow.
less than 4 visits, like less
Wow.
than a month. And I was just hooked. I was like, I need to learn this stuff.
Yeah.
And I also started noticing, I was noticing this for a while anyways, because we were in an office, we got a lot of referrals from gynecologists and OB practices for like SI joint pain, pubic symphysis pain. And we were treating these women, but they'll also be like, well, but like, I'm also leaking. Can you tell me what to do about that? It's
Mm-hmm.
like, I don't know. Um,
Yeah.
or like this was 2008, so
Yeah.
it was also like, yeah, but I don't know, I think there's someone who deals with that, but that's
Hmm.
not me.
Yeah.
So I knew that I needed to add that piece into my
Okay.
practice. So once I started training in pelvic health in around 2013, I have never looked back. So
Wow.
my roots are orthopedics, like a lot of
Hmm.
PTs, but I primarily treat pelvic health now. I treat men, I treat women. My practice is in Mamaroneck, Westchester.
Okay.
I primarily treat in person, but I also do online patients. I have a training for fitness professionals because I really need everyone, all the trainers, all the yoga people, all the people to know that prolapse is not a big scary thing, and do really need to move and train. And that's where real progress happens also in like those Pilates classes. People shouldn't be kicked out of there.
Yes.
And I speak at childbirth groups. I have a son who's 5.
Oh,
And that's my story.
that's amazing. And I love that you brought up back pain, SI pain, tailbone pain. Tell us, because I know there are people listening right now, like nodding their head saying, oh my gosh, I have that. I have SI pain. And they've been told, oh, it's just your SI joint, right? Like it's isolated on that. Tell us how, however you want to anatomically, however you want to kind of bring us into it. How does the pelvic floor affect SI pain, low back pain, tailbone pain? How would they go hand in hand for clients out there?
Okay, so I'm going to show you a model, but I know that this is also like audio podcast.
Yeah.
So someone who's not listening, I'll try to explain. We have a pelvis, which is basically three bones, like three separate bones: pelvic bone, and there's a bone in the back called sacrum. If if there were no muscles and there were no ligaments, these bones wouldn't be together. That's not true for shoulder. Like, shoulder is a socket and a ball that
Mhm.
fits into it, and hip is a socket that ball fits into it. So there's some bony congruence there. In this pelvis, there's some bony congruence, but mostly it's just flat bones put together.
Mhm.
And these flat bones stay together because of ligaments, like big ropes into the pelvis, but they also stay together because of muscles. And the muscles that keep this pelvis together and stable and functioning are lower abs, lower back, glutes, and then from the bottom, it's just all pelvic floor. So the function, that's not the only function of pelvic
Right.
floor, but pelvic floor anatomically is going to function well when the whole pelvic girdle or pelvic ring is in a functionally stable place.
Mhm.
And if that's not the case, because your SI joint's not doing well, or your lower back's not doing well, or your lower abs diastasis is not doing well,
Yep.
it indirectly will flow into pelvic floor. And same thing happens when the pelvic floor is weak or
Mhm.
tight, your lower back and your abdominal muscles will start to compensate. And I often tell people, I your body is not going to care how much your back hurts if it has to choose between not peeing your pants or standing up straight. Your body will always choose not peeing your pants. You won't even know it's choosing that,
Yep.
right? So a lot of times it's the pelvic floor dysfunction or pelvic floor weakness or pelvic floor tightness or even pelvic floor injury,
Mhm.
tailbone injuries that people are sort of like working around by sitting funny, by walking funny, by exercising differently, and the load is going to different structures, which often is SI joint, lower back, and abdominals. Groin probably is also. Hip gets very involved. But anatomically, these joints are literally centimeters, inches away from pelvic floor. Most of the pelvic floor attaches to a lot of pelvic structure, so it doesn't. I mean, it's a no-brainer that it'll be affected.
Yes. And
It's
that,
I think I read a study some one time, and I could probably find the citation that more people have there was closer correlation between pelvic floor dysfunction and lower back pain than obesity and lower back pain.
yep, I believe it.
And uh, correlation is not causation, of course,
Yep.
but there's more correlation there than obesity, which is often blamed for lower back pain.
Yes. And that really perfectly kind of explains why this idea of, in the past, of just do Kegels, that's all you need for your pelvic floor, that really is a fallacy. I mean, we know that through studies now, but also just common sense with what you talked about. Two things. One, the idea that you can simply work your pelvic floor in isolation really doesn't work, right? Like, it has to work with so many other structures. You have to look at everything else. But two, it's not just that the pelvic floor is weak. I mean, there's so many things. So can you talk to us about kind of the differences and the nuance between a tight pelvic floor, a weak pelvic floor? Some fibers can be tight, some can be weak, that it's just not coordinating correctly. What are kind of all the things you see when it comes to true pelvic floor dysfunction?
Yeah, I think you kind of named them all. So one pelvic floor dysfunction that a lot of people know about is weakness, like
Hmm.
the whole pelvic floor is weak. And honestly, that's rare. It's
Yeah.
rare for the whole pelvic floor from front to back to be
Hmm.
just weak. It's very often like somebody has a big nerve injury or something, big spinal injury, maybe we find that, but it's rare for everything to be weak
Hmm.
unless there's a major injury. A more common finding, even in people who truly are weak, are one part of the pelvic floor being weak and one part being tight.
Hmm.
And especially in postpartum, we see the front of the pelvic floor closer to the vaginal opening is weak, and the part that's closer to the rectum is actually pretty tight. And tight probably is not the right word, overactive, like
Okay.
taking over always. And in these people, we see that the back part that is tighter, they are using it when we ask them to do a Kegel, they do
Mhm.
that even more. So they tuck their tailbone even more, and the back part of the pelvic floor is strong in them. They have a good call on it. They have good coordination about of it, but it's much too far to
Okay.
actually help bladder. And when they try to keep doing that, they
Mhm.
actually reinforce that imbalance, right? And when they're doing their Kegels, they get tight, they get even stronger, even tighter back there, and hence even weaker in the front. So that's a very common postpartum finding. Women who have their pelvis tucked underneath them, they're kind of chronically squeezing their butt or tucking their butt underneath, and their backside of their pelvic floor has very poor mobility, and the front side, and they in this tucked posture they keep trying to do more and more Kegels, and it's like, I don't have any muscle in the front. And I'm like, it's almost like your fist is half made, and it's like, I can't make a fist. Well, you're
Mhm.
already making a fist, so if you stop making a fist, maybe you can make one.
Right.
um, that's the very common postpartum presentation. Then there are people who are in tight patterns all throughout front
Yeah.
and back, and very often are people who have chronic pelvic pain, endometriosis, adenomyosis, sometimes bladder pain syndromes tend to have that, and these are the people who have higher inflammation for whatever reason in the body, and the pelvic floor is taking the brunt of it. So they they have chronic pain. They're generally not pregnancy related, although it
Mhm.
can be pregnancy related too. And then there are people who are very specifically tight in the back, closer to rectum. People who sit a lot,
Mm.
people who have habits of tucking their pelvis. That's how they've learned to engage their core, by tucking their pelvis. People who are constipated tend to have that.
Mhm.
So, or people who have been told to sort of stand in a or
Yeah.
work out in a way that causes their pelvis to tuck all the time. So, they'll be the people who have constipation driven tailbone kind of pain,
Mhm.
or tailbone, of course, tailbone sports like horseback riding and
Yeah.
falling on skiing, and
Yep.
those sports, I call them
Mhm.
tailbone sports.
Yeah.
And um, and then there are people, a very large majority of people, especially in postpartum,
Mm.
that don't fit in either one of those
Yeah.
categories, and they just, their pelvic floor is fine. It's fine in the front, fine in the back, fine everywhere. It's their diastasis that the pelvic floor is compensating for. It's their
Mhm.
it's their back pain that
Yeah.
pelvic floor is compensating for. So there are people who have pelvic floor issues
Mhm.
but don't have a pelvic floor problem,
Right.
or
Okay.
people who have prolapse but have fine pelvic floor. Pelvic floor is fine. They're just, they have prolapse because they had a birth injury, because they have hypermobility, because of something else, shape
Yep.
of their pelvis, but their actual pelvic floor is fine.
Yep.
So that's also a presentation.
And do you find when you see these wide groups in physical therapy, and I'm guessing the answer is yes, but you can talk us through it. I mean, I can't imagine being able to really decipher all of that without an individual consult, just because of that idea of everybody is a little bit different. I mean, we all probably need pelvic mobility. We all probably need breathing and thoracic mobility. I mean, there are things I assume just about anyone is going to need and benefit from.
Mhm.
But from there, do you find most people would benefit the most from an individual consult in some way, shape, or form?
Absolutely, yeah,
Yeah.
100%. And especially if you're having symptoms,
Yeah.
because sometimes, a lot of times, the presentation looks very similar. Like, you're leaking. If leaking is the problem, then are you leaking with an urge? Are you leaking when you run? Are you leaking when you're having sex? Are you leaking when you have no? Like, they're all leaking.
Yeah.
And if all leaking means strength training or just doing Kegels, not even strength training, then leaking is just a symptom. And of all the presentations I just said, anyone can have leaking.
Yeah.
Leaking is one of the most common symptoms, and it won't tell us. So, at least at the very minimum, some kind of detailed history taking and putting the
Mhm.
puzzle pieces together is
Yep.
necessary.
Yeah, and virtual, and I love that you said you can do it virtually. And so I just want to make sure anyone listening knows there are general things you can find online. I mean, I even have general ones, so you can definitely start there if seeing someone individually isn't accessible to you. But just keep in mind, doing 100 Kegels a day isn't necessarily what you need or would benefit from. So try not to categorize yourself as just having weakness or just having tightness when, like you said, there's so many different pieces to it.
Yeah, exactly. And almost no one needs
Yeah.
hundreds of Kegels in it. It's like
Yes.
not. I
Agreed.
don't even say rare. I don't. I have no one who I prescribe that to. If you were completely incontinent, leaking your full bladder in bed because you have a huge nerve injury,
Yeah.
maybe.
Right.
But other than that, like, that person already knows where they need to go.
Yes.
That's not you. That's not
Yep.
most of our listeners.
Yes, absolutely. Are there any symptoms? Actually, why don't you just run down general symptoms for us? We've talked about leaking, we've talked about low back pain. What are other general symptoms that you see or that women might want to check and say, you know what? That does sound like me.
So, one of the common, so I'll go with like pre-pregnancy first, like just regular pain, perineal pain, like pain in your perineum around your vagina, vaginal opening, with pretty much anything. That should not be painful anytime, not with sex, not with bowel movement, not with sitting. Um, Pain with sex is a common one in population. Pain with bowel movement, Chronic constipation, now chronic constipation has many reasons, but chronic constipation in a way that feels like your poop is soft.
Mm,
You have an urge to go, right? And your poop is soft. If you have an urge to go and your poop is soft and you still can't empty,
mm,
right? Then you probably have some pelvic floor dysfunction going on. And then in postpartum or even without postpartum, leaking is a big one. Pubic symphysis pain, like pain in the front of the pelvic joint, is another one. Will have painful sex, painful urination, painful bowel movement, or difficulty bowel movement in postpartum as well. Prolapse happens very often after pregnancy, can happen before too. Prolapse is descending or sagging of the organs from their place, sometimes causing them to sort of bulge out of the vagina
mm,
or sometimes rectum. And the symptom I most often hear is it feels like women say something feels off down there, feels like
mm,
things are in wrong place, or there's a tampon sticking out of my vagina, but I don't actually have a tampon. Some
mm.
people will say, I feel like I'm sitting on my vagina, like I'm sitting on much more of my vagina than I did. Um, Vulvar pain, vestibulodynia or vulvodynia is pain at the vulva incited by touch. So we're just touching. There's no internal anything, and just touching the skin at the opening is causing pain that can come from nerve inflammation, hormonal reasons. So vulvodynia is another one. What did I miss? Men have it. Erectile
Yeah.
dysfunction is another one. Prostatitis, urgency, having to pee all the time, not peeing enough times. That's another one. Nocturia, waking up a lot at night to pee, or peeing and feeling like you can't empty your bladder, needing to push and empty your bladder. I think I got it all.
Okay.
There's a lot of symptoms.
Yes, there are so many. And so many too are ones that we're told, especially as women, that's just normal, right? I mean, you talk about postpartum, how often are we told, oh, it's just normal. It's just normal.
Yeah,
It's just part of
just
it.
not.
And then same, I'm guessing, do you also see quite a few women through that kind of perimenopause, menopausal transition as estrogen decreases and prolapse possibly increases? That's also a time where we're told, oh, that's just normal. But I'm guessing you're seeing quite a bit in that population as well.
Yeah, yeah,
Yeah.
absolutely. And the awareness definitely improving now. People are seeking care.
Yeah.
Um, well, I'll often find whatever was in postpartum, kind of gets better or gets stabilizes.
Mhm.
And then unless we're working on it, that kind of gets magnified in perimenopause.
Mm.
So,
Yeah.
like, if you had a little bit of leaking, but it was like, if you coughed 5 times, you had leaking, but other than that, you didn't. Now, and perimenopause, the leaking sort of increases. Or people will
Okay.
say, I had no prolapse, or my doctor told me I have a small prolapse, but was never symptomatic, or I was told to go to PT, but I didn't go because I had no symptoms, and now I'm 45 and I'm starting to suddenly have so many symptoms.
Yes.
So we'll see that whatever happened in postpartum gets magnified.
Okay.
um, I also have women who have, me included, actually had a third-degree tear in childbirth, and I did work on that scar, but that scar that was like very stable for a while. Now that some perimenopausal changes are starting to become a little bit more uh, present.
Yeah. Yep. And so, taking all that, let's transition a little bit into movement because, yeah, one of my probably greatest pet peeves in life, and being someone who has been there, absolutely. I mean, diagnosed grade 4, and I had all the surgeries for prolapse repair. I know what it's like to be afraid of movement. I know what it's like to be told I can't move. And I also know what it's like to say that's not an answer. Like, I have 2 young kids. I am still young. I'm going to move, and figuring out a way to do it. So one of my pet peeves is really when women are told they just can't move anymore with
Yeah.
pelvic floor dysfunction. So let's jump into safe movement. Tell us a little bit about kind of your philosophy around movement with pelvic floor dysfunction, and then we'll get into, I definitely want to hit like squatting, running, and a few specific movements.
Okay. So basically, there's the whole logic of not being able to move, or not, or the suggestion or advice of not moving, comes from the research where it says that when there is increased intra-abdominal pressure, there is increased pressure on pelvic floor, hence increased pressure on organs,
Hmm.
hence more prolapse. um, so that's where it comes from. We And that's not untrue, that's true. The problem with that is there are two problems. One, there isn't intra-abdominal pressure that we can avoid. It's not an avoidable thing. You can't live your life. So there's plenty of studies that have shown that intra-abdominal pressure while getting up from bed is actually pretty similar to squatting. Like, if that is, you can't avoid getting up from bed, right? So that's one thing. The second thing is, research also shows that once we start building more muscle in hips and glutes and back, then we can actually decrease that intra-abdominal pressure with that same activity. So if you have less muscle mass, mass in your glutes and less mass in your inner thigh, let's say, and you're getting up from bed, you're doing a squat because you're getting up from bed, you have some intra-abdominal pressure. You would have more intra-abdominal pressure if you had less muscle in your glutes. So it makes sense for you to improve your prolapse, or prolapse symptoms, to decrease intra-abdominal pressure. It would make sense for you to get more glute muscle.
Hmm.
But the advice you are given is don't work out, which inevitably leads to loss of muscle mass, which inevitably leads to more prolapse or more symptoms, which then leads to women thinking, I'm going to get worse no matter what.
Right. Right.
So we can't take away gravity. Gravity is going to stay. So we have to find ways to actually build more muscle that
Hmm.
will counter that activity. So the goal isn't to avoid intra-abdominal pressure, because we can't. The
Yeah.
goal is to modify it. We
Yes.
have to modify intra-abdominal pressure so that we can do the same activities that we were doing before, giving less pressure to the same structures. And there are many ways to do that.
Yes. And I love that example so much. I mean, because you're exactly right. We have to do life. I mean, because that's what we're kind of telling women in any case. I mean, pelvic floor is just a part of it. But I just spoke with someone yesterday about osteoporosis, and it's kind of the same. I mean, the fear involved with osteoporosis and not moving or not lifting weights, it can be extreme, and it's very real. So I'm validating that for any of you who have it or have heard it. It's a very real fear. And also, I always ask myself, well, what's the alternative? The alternative to yeah, exactly what you said, I could make my prolapse worse, but also my bone health suffers and my muscle mass suffers and my chance for dementia goes up if I don't move and don't exercise. So the choice is to find someone who is going to empower you and teach you how to move safely. And I think understanding exactly what you said, to modify. I mean, I understand this is a management, something I will manage the rest of my life. Like that's realistic, and also I'm going to figure out a way and do it. So I think marrying those two sides for anyone listening is really important. Is meet yourself where you are, let yourself grieve for a day if you need to, and then just get at figuring it out and modifying as you need to and figuring out what you can do instead of focusing on what you can't do, because I know that's a big part of it.
Yeah, and for most things in life, like gradual exposure or graduated exposure is a powerful tool. It sounds very simple because it is very simple, but done over time, it's like it's magical what people can do if you just start doing a little bit and keep doing it. So, you people always overestimate what they can do in a month, but they always underestimate what they can do in a year. Like, if you just stick with it for a year, you will do more than you thought you would do, and it's just hard to get people to stick for it that long
Yes.
without getting discouraged sometimes.
Yes.
But
No,
if
you're
it's if you just think of what three things can I do this today to get a little bit stronger, to challenge myself, it will just keep going forward most of the
yes.
time.
No, that's exactly right. I love that. So talk us through, we'll start with the squat. Again, I told you we'll get into the nitty-gritty here.
Mhm.
Can people with pelvic floor dysfunction do squats?
Yes. So pelvic floor dysfunction is probably a broad term,
Yes, you're right.
in
It
a way
is.
that different things could be going
Yeah,
on.
that's true.
But almost no one will not be able to do squats, because literally getting out of bed or getting up from car chair is a squat. So you will be able to, you have to do the squat. And squat is actually a multi-joint movement, so
Mm.
it's a pretty friendly movement. If you think about it, your ankles are moving, your knee is moving, your hip is moving, your back is moving sometimes. So there are many different ways to distribute the strain of the movement, or or pressure of the movement. um, Depending on what you present with, you may be doing a sumo squat, you may be doing a straight squat, you may be doing a chair squat, you may be doing a squat halfway, you may be doing a squat from 60 to 90 degrees only. So you may be making some modifications depending on where you are, but everyone will do squat. And
Okay.
everyone, I dare say, everyone benefit from doing a squat.
Yeah. And so, if I hear you correctly, you're saying it is not off the table for people, and you're going to start everyone that you see will be doing a squat in some way, shape, or form because it's functional. But
Mhm.
it just might look differently depending on their presentation, depending on their ability. You might start at a different spot and then kind of address that gradual, like you said, kind of the gradual exposure over time to it and probably progressing as they're able to.
Yeah. And squat brings opens the pelvic outlet a little bit, at least some kinds of squats do, and you're getting to the gravity, you're giving
Yeah.
into gravity, right? So both of those things will cause the pelvic floor to take more weight of the organ than it did in standing. So there is that is where the fear comes in. So I'm not saying it's not going to cause symptoms, but there is always a way to do a squat without triggering symptoms. And that may mean we're going to take the gravity out and have you do a squat on like a Pilates reformer. Or it may look like we are going to have you do a wall squat where your back is against the wall to give you more support there. That may look like we're going to put a ball between your knees to squeeze so that your inner thigh can help. There's so like a million ways to support depending on what your body needs.
Yep. And that's why we have to be so careful of that all or nothing kind of mentality, which again, I know comes mostly online because that's what
Mhm.
happens. I mean, people want to be real cautious when they write something. So if somebody's reading it, they're going to say, just don't ever do a squat. And that's honestly, I see doctors and surgeons all the time. They're just going to say it to protect the surgery that they did. My surgeon even said it. Well, if squats hurt, just don't do them. That's not helpful to me,
Yeah,
sir.
and the thing is, it doesn't even protect the surgery. That's the sad part, because they can tell you don't do a squat. They can't tell you don't get up from a chair, right?
Mhm.
So, or don't sit in a chair. You're going to do that. So now you're doing it, and you're not prepared for it.
Right.
Versus you could have been doing it, like, because if you said, okay, don't run a marathon, I guess that makes some sense. But don't squat makes zero sense, because life.
Life. Exactly. You're going to be doing it. So train to do it well. All right. Talk to us about running. What are your thoughts about running?
So, again, running is a basic skill, right? I believe everybody should be able to run to, like, to catch a bus,
Yeah.
or run to, run after your kids. I do that. But long distance running is obviously a personal choice. I don't think it's off the table for anyone at all. It depends where you get, how you get there, and how long that road is to get there. It is a significant amount of impact. So one of the things that I will say is, you have to, running isn't going to be, women do this often in postpartum. It's like, running is going to be my workout, I'm going to get stronger by running. It's like, running is a workout, but it's not isolated enough, it's not nuanced enough for you to actually build muscle that you need to build. So in postpartum, at least, I will say you have to earn your run, at least
Mm.
earlier. You have to strength train, you have to pay attention to your core, you have to pay attention to your pelvic floor. You will run. So, in the beginning, earning a run is more of your mental health, which I totally get. You want to run, you're going to run. But running isn't going to be your workout.
Yeah.
People with pelvic pain very often are scared of running, again, because the pressure. But I feel like if you don't have an obvious injury, running a little bit just creates mobility, creates a little
Yeah.
bit of hormonal changes, and it is not bad. It doesn't really, it's, if your pain is was if there is pain before the run and there's pain after the run, but you feel better because you ran, you might as well run.
Yeah.
That often is the case with people with adenomyosis or endometriosis or like generalized inflammation. People with prolapse do need to be mindful because it is one of the times that there is increased pressure and gravity plays at you again and again. So, but there are a million ways to change that. Again, you have to earn your run, you do have to
Yeah.
strength train, you have to break down the movements, practice them with resistance. Then you have to go baby steps, add impact, prepare for impact in all different ways.
Yeah.
Because pelvic floor, what it does under impact is very different than what it does under no impact.
Mm.
Regardless of how much load there is, whether you're holding weights or not, what
Okay.
it does with impact, which is like eccentric contraction followed by concentric contraction, like it gives and it catches
Yeah.
quickly, is very unique to eccentric movement. So you can only train that with load. You have to prepare for it.
Okay.
um, and then if weakness is majorly a cause, or hypermobility, or stretching of ligaments is a major hurdle in your way, then pessaries are a great way to modify that.
Okay.
It's a passive support that goes up into the vagina. And as long as you know the form of running, you know how to contract, you know how to breathe, you know all the other things, and you're prepared for your run, pessary can be a great tool for just helping that extra passive
Yeah.
support that you have lost because of prolapse.
Okay. I'm probably going to steal that the rest of my life. You have to earn your run. That is so perfectly said, because I think we do take for granted that we should just be able to run. And I know so many people, especially if you could in your 20s. Let's say you used to be a runner. I mean, I hear that from everyone. I was a runner. I was a runner. When an injury happens or a diagnosis or something, and you suddenly feel like running is taken from you, it does feel very much like, well, I should still be able to do that. Like I should just be able to still do it. And it's again part of that accepting of you probably still can in some way, shape, or form. Maybe not the same, like you said, maybe not a marathon, and now you have to earn it. And that's okay. It's just where you are now. And absolutely, I say, I never liked to run. I was never a big runner, but I love to trail run. It just makes my soul happy. Trails feel better on my pelvic floor and my prolapse. Trails always, they're softer, but I manage it. And you're right. I earn the heck out of it. I mean, the only way I can run at all safely is because I lift, is because I strengthen, is because of mobility. There's no way I could go out and do it without earning it.
Yeah, and that's why the running to get back in shape, and running to
Yep.
lose the belly, and running to using running as a tool to get back to your in postpartum self is kind of faulty, because
Yep.
running is actually a straining movement, in all honesty, postpartum,
Yep.
because your pelvic floor went through such a stretch, and now
Mhm.
you're going to put it under load with impact. It's not a bad thing, but it is a demanding thing, and
Yep.
you haven't given it any support. So that's the first thing women start doing at three
It is.
months like, I'm going to just start running, because if I run half an hour, I burned all these calories, I will
Yep.
lose all the weight.
Yep.
And
No,
it's
you're
a
right.
that's a faulty way of thinking.
Yes, and it is. It's all over social media for some reason. And I think if you guys want to listen, I have a whole podcast actually about running and if you even need to be doing it, because my personal opinion is you don't. I mean, Nidhi's exactly right that yes, it is. It's a function that we need. You're right to run after. I mean, it's part of survival. It's innate survival that you run away from a bear if it's running after you. So yes, we should be able to do that. Run after our kids. I want you to feel comfortable running across the street, but it does not have to be a part of your long-term exercise program. If you don't want it to be, if you don't like it, if it doesn't work for your body, there are so many other more efficient ways to burn calories, like you said, and strengthen and all of that. So if your mind is around that, definitely kind of dive into that a little bit. But the idea of, yes, earning your run, that it should be kind of an extraneous part of your workout if you want it to, but you have to work for it, I think is so great. It's such a great mindset shift. It's
Yeah,
awesome.
Absolutely.
All right, talk to us about lifting weights.
So, everyone and anyone should lift weights. Everyone. I really do believe that. From anyone who is in pain, which is a big statement, even if you are in pain, um, lifting weights is most likely going to help you in some way. It just depends on what weight you're going to lift and how you're going to lift it.
Okay.
Because once again, we unless you are going about life without lifting your groceries and without cooking and lifting your laundry, you cannot live without lifting. Lifting is, so many women postpartum, especially with prolapse, are told like not lift, or they are so scared that like they take these 2 pound weights and do a little exercise. And I'm like, how much does your baby weigh right now? It's like,
Mm-hmm.
he's 15 pounds. Like, and in 6 months he will be 25 pounds. What are you going to do?
Mm-hmm.
So first thing I'll say, you buy weights similar to your baby's weight. That's what
Mm-hmm.
you need, because that's what you're going to literally be lifting
Yep.
day in and day out. And never in our life do we actually lift as much as we do in postpartum first 3 years. It just blew my mind. I always knew, but once I became a mother and I
Mhm.
did this for 3 years, like, holy shit, this is
Yeah.
so much lifting.
Yep.
Um, and it's so challenging. Like, you need biceps, you need
Yep.
triceps, you need hamstrings, you really need muscle mass
Yep.
to go through postpartum. And I think that is the reason for high lower back pain and SI joint pain. It's not relaxin. I mean, it could be relaxin in some cases. It's not hypermobility, it's not even diastasis. A lot of times it is just that we haven't ever trained to
Yes.
lift with this intensity and this frequency ever in our life. Even if we were lifting, I was lifting before pregnancy. It was like twice a week of heavier weights. It's a different kind of lifting
Mm-hmm.
versus this persistent lifting all day, every day.
Yep.
So everyone postpartum absolutely needs to lift. I will even tell my patients when I was like, your money is better spent going to a lifting. I can help you lift here, but if you have a gym where they help you lift, your money is better spent. Once a week, go lift there and then come here other time in the week.
Okay.
Because even if you're in pain, a good trainer, a good PT should be able to help you lift to help that pain.
Yep. Yep.
And we find that pretty much that we find that true for most body part
Yep.
injuries, like getting muscle stronger. You can get muscle stronger without making the pain worse. That's just the skill of the practitioner.
Yep. Yep.
If the skill of the practitioner matches what you're looking for, it's almost always possible that you can lift, unless you have a fracture or something, that's a different thing. But it's almost always possible to strengthen a tissue and help that. People with prolapse, I believe, need to lift weight. Not just that they can lift weight, they actually need to lift weight to make their prolapse better. And I see this 100% of time. And people with perimenopause, menopause need to lift for more reasons than we can discuss.
Yep.
They have so many reasons to lift. And yeah, everyone.
Yep. And I know you have a patient soon because you guys, she's gracious to be here talking to us and still sees patients in the clinic. One more thing I want to touch on because you talked about this on your social media the other day, and I think it tags in perfectly with what you're talking about. That there's this idea that we need to get our pelvic floor completely taken care of, either rest it or have all pain gone, all symptoms gone before we kind of start moving or before we go to exercise, before we see treatment, and how that is a fallacy. So, talk us through that, when women should start moving if they need to wait for their symptoms to be gone.
Yeah, so your symptoms going away is partially a reason. So, not everyone, but a huge majority of people have pain because their body does not feel safe. Okay. So, if their body does not feel safe, one, because they have inflammation or something. I'm not talking about those people. People whose body do not feel safe postpartum, or hip pain or back pain or SI joint pain, there are many reasons, but one of the very very common reason is that your body does not feel strong. Your body
Mhm.
does not feel that it can handle this movement of bending over and picking up this kid. So if it doesn't feel strong enough to do that, then you not giving it strength or not giving it more muscle mass is just slowing it down. You can keep waiting and you'll be waiting for a long time. It's possible that eventually the pain will go away and then you will start loading and the pain will come back,
Mhm.
or that you can load, but you took this long way which really wasn't necessary. Unless you have um, unless you have a fracture, or you have an acute, you like post-surgical
Yep.
sort of situation, or you have a blood clot or some other complicated like medical complication, you should be exercising. It really doesn't matter even if you're in a lot of pain. Now it matters, the skill of the practitioner matters, how they get you to move in a way that's not increasing the pain. So I have a back pain patient coming in with a 9 on 10 pain, and the most common advice is just stay in bed. And we all know this has been in research. If you stay in bed for 3 days, your back pain is from 9 to like a 8 maybe,
Mhm.
and then you're from 8 to 7 over next 6 months. Versus if you start moving, then you can go from 9 to 5, maybe still not 0, but 9 to 5 a lot quicker. So body craves movement.
Yeah.
It gives the body circulation, it makes the body feel safe, it makes the body give all the different mapping, it gives our brain different mapping mechanisms between different body parts. Your body's made to move. So if we really don't move, if even in, when you're fractured in surgeries, that's the time you don't move and you pay for it afterwards. But you just have to. Not moving takes away so much from our body that it's almost always harmful. So if you're with a practitioner, doctor or PT or anyone who is not able to find ways for you to move safely, then probably a different practitioner will help in a way that a different philosophy, completely different kind of movement completely will help. But you need to find a way to move.
Yep.
Everyone does.
And we're not saying no pain, no gain. Like you are not fighting your pain and
Mhm.
forcing it. You are working with it. Like you are
Yeah.
working with your body, walking alongside the pain. We are going to normalize it in the time being, saying it's a part of where I am. And yes, movement is a part of the healing process. I think we just forget that is actually one of the tools that we can use the easiest off the bat to help the healing process.
Yeah, and very often it's not all movement that bothers somebody. It's a movement or some movements. So the the skill really is in finding what movement is not bothering you. Let's
Yep.
do that one. And that's where a lot of progress happens.
Yep. Thank you so much. I know you have a patient to see. Tell everybody where they can find you.
I hang out mostly on Instagram. My handle is pelvicharmony.pt. In my clinic, you already have the dress, so
Awesome.
please
Yep.
connect.
Okay. And we'll have the links below. So if you guys want to go check all of those out, thank you so much. I am just so thrilled and I loved this conversation. And thanks for being here.
Thank you, Jessica.
Mhm. Thanks so much for listening today. I would love it if you could take a moment to subscribe, rate, and review this podcast. It means a lot to us and it helps our content get out to more women who need it. You can find more of my resources at my website, jessicavalant.com, or find me on YouTube at Jessica Valant and Instagram at Jessica S. Valant.